evening, everyone. So today, our group will present to you about the topic of child with fever. So I will start with the definition. Next slide. Next. Okay, I will start with definition. So fever basically is a normal response to a variety of conditions, which the most common event is when the child got infection. So generally, a fever can be defined as a temperature above 100.4 Fahrenheit or 38 degrees Celsius. However, we might get slightly different numbers depending on how we take the child temperature. So usually doctor will use a reliable digital thermometer to confirm a fever. It also considered as fever when the child's temperature is at or above one of these levels. If we measure the temperature orally is at or above 37.8 degrees Celsius or 100 Fahrenheit, 38 degrees Celsius or 100.4 Fahrenheit if we measure it rectally, or 37.2 degrees Celsius or 99 Fahrenheit if we measure in an axillary position. Next, I will explain about the pathophysiology of fever. So the development of fever begins with the release of endogenous pyrogens into the circulation as the result of infection, inflammatory process or malignancy. So the microbes and microbial toxin act as exogenous pyrogens by stimulating the release of endogenous pyrogens, including cytokines such as interleukin-1, interleukin-6, tumor necrosis factor, and interferons. And these cytokines then reach the anterior hypothalamus, liberating the arachidonic acid, which is metabolized to prostaglandin E2. And then the elevations of the hypothalamic thermostat occurs via a complex interactions of complement and the prostaglandin E2 production. And the elevations hypothalamus set point will cause the vasoconstriction, causes shunting blood towards the internal organ away the peripheries in order to increase the heat conservation, which leads to the fever. At the same time, initiations thermogenesis of fat storage in muscles also occur by increasing the involuntary muscular contraction in order to increase the heat production, which lead to the fever also. Next slide. Next.
Hanim, can you tell us what's the purpose of having this? Why the body, or do you have it next slide? Why the body start to produce fever? I mean, like, I know it's in response to whatever the exogenous pyrogen, but why?
Actually, because
What's the benefit of fever, or is it bad, or is it beneficial?
actually it beneficial in order to kill the microbes or microorganism. By increasing, if you increase the temperature of our body, the microbes or the microorganism cannot live in our body.
Okay, all right, okay. So fever is not something which is worrying, like people from outside are worried about fever, but it's actually a body response towards whatever the trigger are, whatever the triggers are. So if the triggers are infection, therefore the purpose of doing so is to reduce replication of whatever viruses or bacteria, so that it does not have an optimum environment for replication, or for getting more, So therefore, it is important. Fever is an important thing. It's not like if you don't have fever, so what's gonna happen?
So bacteria can live in our body and replicate and make worse to our body.
Okay, kill you lah, basically, isn't it? Yeah, kill you quickly.
Yeah.
All right. Okay. Go on.
Okay. Next slide. So, and then we explain about the grades of fever. So in order to grade the fever, so usually we will refer to the rectal temperature. Even though temperature measurement by oral or axillary position is much easier to obtain, but the rectal measurement is the most reliable way to obtain the most accurate body temperature, as it measure internal temperature of the body. So the normal body temperature is usually in between 37 degrees Celsius to 38 degrees Celsius, equivalent to 98.6 to 100.4 Fahrenheit. So if the child's temperature increases and become between 38.1 to 39 degrees Celsius, we will consider as mild or low grade fever. And then if body temperature is between 39.1 to 40 degrees Celsius, we can consider as moderate grade fever. And then 40.1 to 41.1 degrees Celsius as high grade fever, and more than 41.1 degrees Celsius we consider as hyperpyrexia. So it is very important to know about the grading, especially in the high grade fever or hyperpyrexia, because it can make the child become more uncomfortable and can lead to the worsened problems like dehydration or seizure. Next slide. Next. Okay. Next is the causes of fever. So there are 8 causes or patterns of fever. So for the better understandings, I include the graph for each pattern of fever. So the first one is the continuous fever. It can be characterized by the temperature remains constantly above the normal temperature, and the fluctuation value is usually not more than 1 degree Celsius within 24 hours. And the possible causes for the continuous fever usually due to viral fever such as gram-negative pneumonia. The second one is the intermittent fever. So the intermittent fever, it can be characterized by temperature fluctuation is more than the TC or body core temperature or normal body temperature, and the fever is present only for a few hours in a day. The possible causes is due to malarial fever or filarial fever. Next is the remittent fever. So the remittent fever, it has a daily fluctuation more than 2 degrees Celsius, and the temperature does not return to the normal value, usually due to enteric fever. Next is the saddleback fever. It has a light kills patterns, as you can see in the graph at the right side. So the saddleback fever is specifically for the dengue fever pattern. So it characterized when the patient becomes febrile and afebrile for 2 or 3 days each. And usually the febrile and afebrile events will occur within 7 days of duration. Next is the pale Epstein's fever. So it is like saddleback fever pattern, but the febrile and afebrile periods is longer, which is 3 to 10 days each. Usually due to Hodgkin's lymphoma. Next is the indolent fever, or we can call as the quotidian fever. It gives a wave pattern in the graph. The possible causes for this kind of pattern of fever is the brucellosis. Next is the tertian fever. It is a fever relapses every third day, and we can see this kind of pattern in the malaria due to Plasmodium falciparum, ovale, or vivax. And the last one is the quartan fever. It is a fever relapses every 4th day because of malarial fever too, due to Plasmodium malariae. So that's all for me. Thank you.
Assalamualaikum and good afternoon, everyone. So I will continue my presentation with the causes of fever. Okay, as we know, when a child presented with fever, it doesn't necessarily caused by infection. So there could be any other causes as well. Okay, first is of course infection. It can be from bacteria, viral, parasites, or fungal. Second is vaccination. So some vaccination can cause a mild fever, but this is like a normal manifestation for a child to have fever when get vaccinated. And then third is teething. Teething can raise children's body temperature, but only slightly. And then fourth is inflammatory diseases like inflammatory bowel disease like Crohn's disease and ulcerative colitis. SLE or Kawasaki disease. And then fifth is malignancy, like leukemia, lymphoma, and Ewing sarcoma that is common in children. Next.
Sorry, teasing ni is just only low grade fever. It's not really, kind of a high grade fever that we worried about. So the other thing that you are not putting up anything drug related fever, because sometimes when you eradicate all infection, much drugs in it, antibiotics or whatever, long term kind of like use of antibiotics sometimes can fever as well, particular model kind, but having said that, rule out everything
Okay.
many types of drugs related or antibiotics related. So just beware as well. Some of the drugs may also cause.
Okay. Okay, doctor. Next. Okay, so for categories of fever, first is fever of short duration, accompanied by localizing signs and symptoms, in which a diagnosis can often be established by clinical history and physical examination. Second is fever without localizing signs, which is fever without a focus, frequently occurring in children younger than 3 years of age, in which a history and physical examination fail to establish a cause. And then third is fever of unknown origin, which is defined as fever for more than 14 days without an identified etiology despite history, PE, and routine lab tests, or after 1 week of hospitalization and evaluation. For fever in infants younger than 3 months of age, they have higher risk of serious bacterial infections than in older infants, and they usually exhibit only fever and poor feeding without localizing signs and of infection. And then most febrile illnesses in this age group caused by common viral pathogens, but serious bacterial infections include bacteremia. For fever in children on 3 months to 3 years of age, they have increased risk of infection with organisms with polysaccharide capsules, including Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitidis, and non-typhoidal salmonella. This is because the effective phagocytosis of these organisms require opsonic antibody, and opsonization requires IgG type of antibody. So initially, transplacental maternal IgG provide immunity, but then as they grow up, the immunity slowly decreases, and that is why they have higher risk of infection. And then in this age group, the most commonly identified serious bacterial infection is UTI. Next.
Stop there. Okay, what are the things that we need to learn from these slides?
The differences between the categories of fever.
Okay, right. Anything else? So short duration meaning? Time.
They have yes, and they show a localized sign and symptoms.
If it's localized signs, it's easy because you can pinpoint straight away. If it's tonsil, if you have localizing signs, tonsil enlarged, tonsil red, tonsil when you accidentally, it's that's a sign. So it's tonsillitis lah. Nothing proven otherwise, isn't it? That's easy. What about short duration? What does it mean?
Acute fever?
Yeah, I know. Yeah, okay. If it's does he have any bearing in terms of differentials if you have a short and prolonged fever?
In terms of complication.
No, not really. I mean, in terms of etiology. Badrul Amin. Sounds like Ustaz Badrul Amin. I remember Ustaz Badrul Amin in the past. I don't know. Badrul, can you hear me?
Yes, doctor.
Okay, can you give me an opinion on this matter? Short duration versus prolonged fever. In terms of etiology, what do you understand about it?
If the short term, it will be acute, and if long term, it will be chronic. And it would
Okay.
also,
Etiology?
etiology would be the infection, and for
What infection?
it could be viral or bacterial infection.
Okay. Usually, if it's short, it's likely to be viral viral because of it. 5 days. Viral will not go beyond unless if you have immunocompromised, like HIV. Baru lah quiet, isn't it? Then you're gonna get prolonged fever. But if it's a dengue infection, it's very short, 5-6 days. Viral illness or anything with viremia will be very short, unless it's progress to complication. So then when you have influenza virus and then complicated by pneumonia, then it's prolonged lah, isn't it? But whatever short history of fever is most likely to be viral in origin. That's what I want to say. Okay, prolonged fever because if it's bacteria, you don't treat them, they multiply and they get stronger in your body. So unless if you treat them, then they will shock up, isn't it? But if you don't treat them appropriately with antibiotic, which is not really effective or accurate or very specific to that organisms, therefore you're not going to be able to eradicate it. Okay, so therefore etiologically, make sure when you are doing your clinical data, in the purpose of trying to put this is, highlight this is that you should be giving etiology. I mean, like if you have prolonged fever or fever of unknown origin. So therefore, you need to be able to not to say viral lah, isn't it? Because most likely viral is not going to be fever of unknown origin unless if the child has got HIV lah. It's rare lah nowadays, isn't it? The medication that we have nowadays. I've never seen. I've seen, but then it's been like 5-6 years now. I've not seen a child who has HIV because of the drugs, availability of the drugs that is the viral load itself. So rarely you see all these things anymore. So when you are giving differentials of the reason why you got prolonged fever or fever of unknown origin, make sure you do it appropriately. You don't say viral fever or fever of unknown origin. That means you don't understand the pathophysiology behind what is happening to the body. Okay? Okay, number two. So the reason, number two, things that we can take home, message to take home. What about this infant of younger than 3 months? What do you understand about this?
They have
Sorry?
their immune system is not fully developed.
Okay, hence?
They are more attracted on common viral pathogen.
Okay, children or babies under 3 months of age presented with fever need to take it serious, straight away serious.
Admitted.
I don't want to go to discharge anybody or baby less than 3 months of age. So you know the definition straight away. Any children that age less than 3 months old need aggressive. So meaning you need to find the focus of infection. If you could not find the focus of infection, therefore you need to rule out serious bacterial illness. For example, bacteremia or meningitis lah. Okay? Hence, so if it's meningitis, so how do you okay, can you hear me, Wei Hua? Some people are unable to hear. Can you hear me now?
Yes.
Okay.
Yes. A bit soft, doctor.
Bit soft. Okay.
Yeah.
Okay, can you hear now? Okay, can you hear now?
Yeah, can hear now.
Okay, so the thing is, the most important thing is that you need to make sure that whatever you're gonna do, you need to think about serious bacterial problem first before you say, okay, this is nothing wrong with the child. So if the child less than 3 months of age comes to you, you need to rule out serious things. You don't say, okay, this is nothing wrong, the child don't need to do anything, and just observe. No, the baby might die after that. They might just start with fever, maybe non-specific symptoms such as breastfeeding, rash, etc. Non-specific thing. But then at the same time, you need to make sure that this is not something serious like meningitis. So all children or babies less than 3 months should be admitted and work up aggressively. Okay? If you do not remember anything, bring this home. So that when you become a doctor later, you see a child less than 3 months of age, make sure you are doing something, make sure you are, don't take it, lightly on all these cases. Okay, go ahead now.
Okay. Okay, so for types of fever, first is acute fever. The duration is less than 7 days, usually caused by infections such as malaria and viral-related upper respiratory infection, like Dr. said just now. And then some vaccinations can cause fever either in the first 24 to 48 hours after the vaccine is given, for example, pertussis vaccination, or 1 to 2 weeks after the vaccine is given. These fevers typically last from a few hours to a day. While subacute fever, the duration is less than 14 days. For example, typhoid fever and intra-abdominal abscess. For typhoid fever, we have to ask the patient for any history of if they have eaten at roadside stalls so that we can rule out for the transmission of contaminated food and water. Next. Okay, so for prolonged fever, the duration is more than 14 days, usually caused by typical of chronic bacterial infections. However, any cases of acute fever can become persistent or chronic if left untreated. So the causes of prolonged fever are divided into two. First is infective causes, such as bacterial infections like Bartonella hensela and Brucella species, deep abscess like intra-abdominal abscess and retroperitoneal abscess, infective endocarditis, and tuberculosis. For non-infective causes, such as inflammatory disease like systemic lupus erythematosus, Kawasaki disease, and inflammatory bowel disease. And also malignancy like leukemia, lymphoma, neuroblastoma, and Ewing sarcoma. Next. For Kawasaki disease, it mainly affects children of 6 months to 4 years of age with a peak at the end of the first year of life. And the diagnosis is made on clinical features. First, the child must have fever over 5 days and at least 4 of the 5 cardinal features. First is bilateral non-puerile conjunctivitis, injected pharynx, red lips, dry facial lips, and strawberry tongue. Is edema or erythema of the hands or feet, and desquamation, which is peeling of the skin beginning periingually, and then rashes, usually at truncal, polymorphous but non-vesicular, and cervical lymphadenopathy. So children with Kawasaki disease are often strikingly miserable, which is not improved by oral antipyretic agent. So if the children come with a fever persisting for at least 5 days, and at least 4 of the 5 cardinal features, we must suspect for Kawasaki disease and manage accordingly to avoid any complication. So for the treatment, they will be given IV immunoglobulin and also aspirin. Aspirin is to reduce the risk of thrombosis. And then for complication, the child might get coronary artery aneurysm because this is a vasculitis disease and it may affect the blood vessels of the heart and causing bulging of the weakened blood vessels, and that is why get coronary artery aneurysm. So if there is any blockage on the coronary arteries, might cause myocardial infarction. And also, if you can see on the right side, there is an investigation to actually support the diagnosis of Kawasaki disease. So investigations are done. At the first week, you can see increase in white blood cell, increase in CRP and ESR. And also on the second week, you can see increase in the platelet. Next. For fever of unknown origin, first, the definition is the temperature greater than 38 degrees Celsius lasting for more than 14 days without an obvious cause despite a complete history, physical examination, and routine screening laboratory evaluation. So, the common routine screening lab include complete blood count, ESR, CRP, hepatic transaminase levels, urinalysis, urine and blood culture, and chest radiograph. But if there is still no diagnosis, they can proceed to additional tests like special culture like stool culture, throat culture, and if they are considering malignancy, can go for bone marrow examination and imaging studies like CT scan or MRI to detect any abscess or tumor. For the causes of fever unknown origin, first for infectious bacterial, which is Bartonella or tuberculosis, for viral like cytomegalovirus, hepatitis, Epstein-Barr virus, HIV, and then for non-infectious like malignancy, which is leukemia, lymphoma, and neuroblastoma, for autoimmune, juvenile idiopathic arthritis, and SLE, or for other non-infectious, like Dr. said just now, the drug fever, which some people might be allergic to certain medication, but if we stop the fever, it should evolve. Next. Okay, next is diagnostic approach for fever unknown origin. So for history.
Can I just add fever of unknown origin? Can you just go back a little bit before you go on next?
Yes, Doctor.
All these things, make sure when like if you say infective endocarditis, who is at risk of infective endocarditis?
How?
No lah, mana lah. If you go to dentist, you're gonna get bacteremia, but your immune system will be good. So who's at risk then?
Poor left condition.
Children who have valve
Children with what is it?
valve problem.
Congenital heart lah, basically. So whoever who's got congenital heart problem, then they are at risk of bacteremia because of maybe because of procedure from or procedure tooth extraction. Then when they get bacteremia, then all these bacteria can deposit in valvular disease, or by coming from congenital heart. So if you don't have any congenital heart, you're not going to be exposed, basically, isn't it? Okay. Next bit. Can you go back a little bit on your slide? No. Okay. Right. Okay. Any other things that you can think of? Pyelonephritis. Those at risk.
Kidney problem.
Okay. So, which one? Which children who's got pyelonephritis?
UTI problem. If
yeah, not directly lah. I mean, what about those? I mean, who's at risk of pyelonephritis? No, not really. We're talking about pediatric now. Don't go beyond pediatric. I don't want to know about adults. So children who has vesico-urinary reflux, isn't it? So when you have a reflux of your urine, it should be draining from ureter, to the bladder. therefore you're gonna get, you're gonna be prone to have pyelonephritis, upper urinary tract, kind of like infection. What about TB? Who's at risk? Children? Which children? Sorry?
Those exposed to the bacteria, if the parents have occupational exposure.
Children TB is usually
Malnutrition.
Malnutrition in third world country lah. It's not in our country. So in our country, usually it is because exposure to adults. Adult is infectious. Tuberculosis in adult is infectious. Tuberculosis in children usually are they infectious? Anybody?
I'm not sure. Doctor.
No. Then not sure. Okay, Wei Hua.
Yes, doctor.
TB in children is it infectious or not? Children is it infectious or not?
I think should be infectious. Is it the children at the daycare center?
So who gets TB? Who gets TB in kids? In kids. Which children? Which children? Or what type of presentation?
Cough.
Cough.
Night sweat.
No, it's not cough. Children will get extra pulmonary manifestation. So that's why they got all this what you call it, adenopathy lah, TB gut lah, TB meningitis. So that's children. Okay. Adult, they present with the pulmonary TB. Pulmonary TB is very, very infectious because they can give it to children lah basically. Children punya presentation very rare to present as pulmonary TB. It will be extra pulmonary manifestation. You don't know lah. It can go to blood, it can go to wherever lah. It can go to meninges, it can go to kidney, it can go anywhere basically. It can become malaria, it can become swamp. So basically, adult usually is the one who is giving the what you call the organism to children. So therefore, history of contact is much more important. History of contact in adult, which is much more important because the adult is the one who gives it, and then they will present with lymphadenopathy or swelling anywhere lah. Or Scrofula. Find the words, okay? So okay, TB. What about non-TB mycobacteria? History of what history do you need to take? So you need to take some of the exotic punya history. Contact with animals, tracking, isn't it?
Yes.
Playing with birds or whatever lah, birds or animals are animals. So so history, it does not mean you are focusing on the fever history itself. It might be the most significant history is to get to know, okay, whether they have any significant history of traveling in the jungle trekking or not, isn't it? If you have jungle trekking and you've been what you call bitten by tick-borne disease, so you're going to develop Lyme disease, tick-borne tick. So I think all this history, simple things is you're going to look for viral. Another simple one, you're going to look for what are the causes of bacteria. But if you can't find it, especially if people of unknown origin, therefore you need to explore more. What about the traveling history? What about the contact? Isn't it? Is there any exotic animals or not? Do did they go to, like Lepto, did they go and swim in the river or not, isn't it?
Yes.
So must be relevant to what you can think of. This is much more difficult to piece off because it is a broad kind of like condition if you're going to look for paraxia of unknown origin. All right, okay, next.
Okay, doctor, thank you. Okay, for history, ask for any local exposure, like contaminated with food or water, like Salmonella typhi for typhoid fever, or ask for history of exposure to animals. Like doctor say, if the child when swimming at the waterfall could also increase the risk of leptospirosis, rat bite fever, or Bartonella hansella also. And then for travel history, like for certain country, if they
Bartonella tu kucing, okay?
kucing, okay, sorry. Next, for travel history, for malaria vaccine and hepatitis A vaccine, sometimes if they travel to certain country that have particularly high prevalence of the disease, they must take the vaccine. So ask for travel history. And then for family history, ask if there is any genetic disease that run in the family. For physical examination, assess for if there is any mouth ulcer, or and then if there is any conjunctivitis, rashes, joint abnormalities that could indicate SLE, and then lymphadenopathy, and also hepatosplenomegaly or palpable abdominal mass that might indicate malignancy. Next. Okay, for treatment, the treatment varies depending on the causes. So first is non-steroidal anti-inflammatory drug, which is NSAID and antihistamine, like acetaminophen and ibuprofen, to treat fever unknown origin that have no trace of underlying causes. And then second is broad-spectrum antibiotic. This is used in immunocompromised patient that is susceptible for opportunistic infection because they have weakened immune system, so we give broad-spectrum antibiotic. And third is antiviral drugs to treat HIV-associated fever. Okay, that's all.
Okay, next I will proceed to discuss about the differential diagnosis when a child came with fever. So we can think of any infection causes, for example, in the respiratory system. If the child come with the cough, sore throat, and runny nose, we can think of the URTI, upper respiratory tract infection. And then if there are some pain in swallowing, we can think of pharyngitis. And then if there are some pain in the ear and there are pus draining, we can think of otitis media. And when there are some stridor and losing of voice, it might be croup. In sinusitis, child might be present with stuffy nose, postnasal drip, and also pain at the sinus area. For pneumonia, the child might come with the productive cough, vomit, diarrhea, and also we can find some findings such as consolidation and more. And then if there are infection in the cutaneous skin, such as in cellulitis, we can look for some red, bruised, and blistered skin or enlarged lymph node. And if there are infection in the abdominal region, we can think of gastroenteritis. So we can ask about the food history and also whether the child have vomiting, diarrhea, abdominal pain, and poor appetite. If we think of appendicitis, we might need to look for any right iliac fossa pain or at the McBurney point and for any guarding and so on. If there are any infection in the central nervous system, we might think of meningitis and encephalitis. But for meningitis, another presenter will present about it later. And then if there are systemic infection, we might think of sepsis. So we need to look for any signs of hyperventilation, any tachycardia, any convulsion, or any shortness of breath. And then if there are fever because of the occult bacteremia occurs, there will only be fever symptom. But this bacteremia may cause other complications such as meningitis and bone infection and more. And then tick-borne infection, like doctor said before, like a Lyme disease, so the child might present with the muscle and joint pain. And then if there are genitourinary infection, like a urinary tract disease, we might need to look for any hematuria, any frequent urination, and for child that already trained for toilet training, if they still wetting suddenly after that, then we might also think of the UTI. And then for the pelvic inflammatory disease, if the girl in the reproductive age come with the food odor, smell, and some burning sensation during urination, we can also and abdominal pain, we can also think of the PID. And there are also miscellaneous cause of infection, such as orbital cellulitis and also fever of unknown origin, like we discussed before. And also, we might think of any musculoskeletal infection. Next. Other than infection, the fever can also because of the inflammation. So we might need to think of the acute rheumatic fever if there are any joint inflammation, or we can find any nodules under the skin or pain at the joint that's migrating. For the systemic lupus erythematosus, we might look for the butterfly rash. And then for the juvenile rheumatoid arthritis, also presenting with the joint stiffness and maybe some limping. And then Kawasaki disease and also inflammatory bowel diseases like Crohn's disease and ulcerative colitis. And then we might also think of the fever that came from the plastic cause like leukemia and lymphoma. So we need to look for sudden weight loss. And then if the leukemia, there might be some easy bruising and infrequently infection before. There are also toxicologic cause and miscellaneous cause of fever. So it is listed there. You guys can read later. Next. Aside from all those things that I stated before, we can also think the differential based on the localizing sign. So for fever with localizing sign, it will be easier because there are focus of the infection around that we can see. For example, like in the meningitis, we can see if there are any headache or any photophobia or any neck stiffness. In otitis media and mastoiditis, we can see we can look for any pain at the ear region. And then for the osteomyelitis, yes?
Can I correct you one thing?
Okay.
Localizing signs, not localizing symptoms, okay? So what meningitis, what are the signs?
Photophobia, headache,
Itu symptoms.
yes.
Key sign.
What, sorry?
Brudzinski sign.
Brudzinski signs ataupun Kernig, isn't it? Kernig,
Yes.
Brudzinski. I think those are the things that's what we should be looking at lah. Okay. Anything else? For example, otitis media. What are the signs?
There are redness at the tympanic membrane.
Thank you very much. That's signs. Okay, not symptoms. Okay. Alright. So
Okay.
everything has got signs on each of them. For example, if you're typhoid, you can have sign, but it's not specific. Typhoid, hepatitis B, it's not specific. UTI, you have, but if it's phyllo, then you might have renal ankle tenderness. Septicemia, nothing but fever only lah. Malaria, maybe hepatitis B, so it's not specific to whatever the underlying problems. Okay, similarly to HIV, it might be hepatitis B, but nothing specific to say what is it, the underlying problem. Rheumatic heart, what do you see? Rheumatic, guys? Jannah? Oh, Jannah, can you hear me?
Yes, doctor. Right.
Rheumatic fever, so what do you see? Clinical sign, localizing sign. Istilah carditis lah kan, nama pun rheumatic fever. Fever that is occurring in a normal patient or child leading to having an acquired heart problem. A child who's normal before this and then suddenly develop a murmur or a carditis punya sign. Tak kisahlah, either epicarditis or myocarditis or valvular involvement. So it doesn't matter. So it's a carditis itself. So rheumatic fever is also a localizing sign lah, so you know from the history. Okay. Alright, okay, continue.
Okay, next. We can also have a differential if the child came with a rash, with the fever. So, for example, if it presented with the maculopapular rash, we can think of the human herpes virus, enterovirus, measles, and rubella. And for the bacteria, it will be the scarlet fever and rheumatic fever and Lyme disease, and also others like Kawasaki and the juvenile idiopathic arthritis. If the rash come in the presentation of vesicular bullous or pustula, we can think of the varicella zoster virus, herpes simplex virus, Kawasaki virus, and Staphylococcus bullous impetigo, and more. And then if the rash come with the rash like petechiae and purpurate, we might think of the meningococcal bacteria, infective endocarditis, thrombocytopenia, and more. Next. So this is just a picture for you guys to see later. It just shows some of the things that we can think of when we see a febrile child. Next. And so I will touch a little bit on the differences between the viral infection and the bacterial infection. Like the doctor has said before, for the viral infection, usually it is have a shorter fever, shorter duration fever, and usually self-limiting. So it can reduce, it can be settled by itself, and usually it have early presentation. But if it is a viral infection, a bacterial infection, they might be symptoms last longer than 10 to 14 days and also worsen instead of improving by itself. And then for the physical finding, for the viral, is the fever is usually low grade, and it came with the painless lymphadenopathy. But for the bacteria, it might have a high grade fever and the tenderness lymphadenopathy. For the investigation for the viral infection, we can look for the low C-reactive protein, and also we can do some PCR test. And for bacteria, we can do some bacterial culture and also rapid antigen detection test. And usually for the treatment for the viral infection, it's just a supportive therapy as it is self-limiting, but we can also give some antivirals. And also for the bacteria, we can give antibiotics. Next.
Wait. Investigation. You're not enough. It's not enough yet. What are the investigation required apart from CRP? So
Apart from this,
CRP is not specific. Whatever you're gonna do is always not specific. So, but high CRP will indicate bacterial infection. So low CRP, okay, will indicate viral infection. Is there any simple test that might give you a clue to what is viral and what is bacterial?
Antigen test.
Okay, but that's specific, isn't it? What is simple test that you do? Usually, if a patient comes to you, what are the most important common investigation that you do apart from CRP? What blood test?
Leukocyte.
Sorry?
Leukocyte.
Leukocyte, okay. Tell me a little bit more, Amirul. Amirul, Muhammad.
Amirul.
Okay.
If leukocyte is normal, it's probably viral infection. But if leukocyte is low, it probably bacterial infection.
Low bacteria?
Leukocyte low is in viral. Bacteria normal. But
Okay.
For example, presence of macrophage, probably bacteria.
Macrophage pula dah. What is this macrophage? Where are you going with this macrophage? Guys,
Leukocyte.
please.
Lymphocyte.
Okay, yes. Try again. So if you have neutrophilia, okay, so increase neutrophil counts, therefore it will indicate more likely to be bacterial infection. So if it's viral, which one is increased or normal or what? Hello?
Lymphocyte.
So you look at the lymphocytes. Usually the lymphocyte is slightly elevated, slightly. Okay? But lymphocytosis can also be bacterial as well. Which bacteria can cause lymphocytosis?
Mycobacterium tuberculosis.
No, not really. That one can be normal. TB. If you see lymphocytosis meaning that the lymphocyte is elevated. Which bacteria? Anybody? Bacteria in the what you call in the vaccination schedule. My clue.
Varicella.
No, not varicella. Bacteria. I said bacteria.
Bacteria.
Bordetella pertussis. Okay. Awak ni dah belajar dah. Everybody has learned microbiology or not yet? You should be learning lah, isn't it? Microbiology. So it does not mean that, I mean, these are all non-specific things, but if you think about a child who's got history, sign and symptoms suggestive of pertussis, the likelihood you're going to see is that they will have lymphocytosis, not neutrophilia, okay? The likelihood. So just beware, whatever you're going to do and interpret all these things, it has to come with a little bit of knowledge, yeah? Okay? And the other thing as well, low white cell can also be bacteria as well, although most likely it's a viral, but it can also be bacterial. I think you're going to touch it later, isn't it? In febrile neutropenia. So low white cells in a child who's immunocompromised, it can also be bacteria. It does not mean it's all viral. It can be bacterial infection. So if it's neutropenia and they have fever, what to think about? Serious thing again. Okay, and then what are other things that you need to look at apart from the differentials in the blood count? Anything else that might indicate viral versus bacterial infection? Can you hear me or not? Can you hear me?
Can hear.
Rawan Al-Zahar, can you help me out?
Yes, doctor.
Yes. What do you think? What do you reckon?
I think culture, we can
Okay,
say.
all right. Okay, so culture, one thing. And what about, I mean, simple things, as I said, from full blood count. What else can you do in full blood count in order to delineate or to state that this is all either bacterial or viral infection in the investigation?
Other than culture?
Mm.
Not sure, doctor.
Okay. Tina? Anybody? Tina? What about you, Tina? Tina, isn't it? T-H-E-N-A? Yeah. Tina, where are you? Very slow, isn't it? Anybody else want to answer? Priyanka? Hello, Priyanka.
Yes, doctor.
What do you think? What do you reckon? Priyanka?
I'm not sure, Doctor.
You're not so sure as well. What about if I tell you, if you do, what you call, black film, smear, blood smear. So what do you want to see?
Parasites?
Okay, not really. Anybody else? Shakila? Shakila?
Is it gram stain, doctor?
Not gram stain. If you do peripheral blood smear, what can you see if you want to look for infection? Have you ever heard about toxic granulation? The term
No.
toxic granulation? Or what about left shift? Have you ever heard about it? Not yet, is it? Okay. Okay, so this is one of the things that you need to go and read it up. Okay. What are the things in the peripheral blood smears or blood films to indicate viral versus bacterial? I said already just now, toxic granulation, left shift. But what does it mean by that? Okay. And that will tell you whether this is a bacterial or viral infection. Okay. So things that comes in the simple investigation, you can also do it. In the if you say culture, if it's become bacteremia, then you can pick up organism. If it doesn't become bacteremia, for example, if you have pneumonia per se, localizing in the lung itself, without the organism itself traveling in the bloodstream, therefore you're not gonna pick it up. You're not gonna get anything from it. The blood culture, yes, it's an investigation, but it does not mean that it will pick up if there is no. It's not going to pick up if there is no what you call bacteremia or septicemia. Okay, that's fine. Okay, go. Next.
Okay, next.
Okay, good day everybody. My name is Arwa and I'm going to talk about the infection in children. We are going to focus on meningitis and dengue only, and this part is an application in order to know the differences between the bacterial and viral infection. So the meningitis is defined as inflammation of the meninges, that is covering of the membrane. This can be confirmed by finding of the white blood cell in the cerebrospinal fluid by obtaining from lumbar puncture test. It is the cause of mortality in about 1,000 people around the world every day in many of the children and young adults. Survivors can be left with the severe disabilities, and there are 5 types of meningitis. We have viral, bacterial, fungal, parasitic, and non-infectious. The viral infection are the most common cause of the meningitis, and the pediatric bacterial meningitis is most common in children younger than 4 years, with a peak in incidence in those aged 3 to 8 months. The most common bacterial causes of acute meningitis is in young children are Streptococcus ehrlichiae, E. coli, and Haemophilus influenzae. So the tuberculosis meningitis is rare in countries with a low TB prevalence. The TB meningitis is mainly affected in children under 5 years of age. The fungal and parasitic meningitis are very rare in children, and the non-infectious meningitis is commonly seen in malignancy and autoimmune disease. Next slide. Okay, how to assess the baby or the child when he have a meningitis? So first we will take a history. You will take a history from the mother that the baby has fever, and the baby is tend to cry, and also headache, photophobia, lethargy, poor feeding, vomiting, irritability, hypotonia, drowsiness, loss of consciousness. It is very important before the lumbar puncture test procedure to know either is it contraindicated or not. Also, if there is any, the baby have any recent seizure in very severe cases. And then you will do and perform the examination. You will confirm that the baby has a fever and has a pulmonary crash due to the damaging of the vessels and leak to the surrounding tissue. Neck stiffness, but not always present in an infant. And also there is a bulging in the frontinel in the infant. And there is stetonus, which is like it's like a contraction, not contraction, it's a spasm of the muscles that is causing backward arching of the head and neck and also the spine. And there is going to be a positive Brzezinski and Kering sign, which is associated with the stiffness of the neck. I will show you after this. And there is a sign of shock, also a focal neurological sign, which is the baby will present with a weakness, is like in certain limbs, the left arm and the right leg, which is called also plegia. There is an altered in consciousness level, and baby might have papilloedema, but this is very rare. Okay, next slide. Okay, this is the Brzezinski and Kering sign. The Brzezinski sign, as you can see in the left picture, the child is lying in supine position. You will try to flex his neck, noticing there is some rigidity, and while you are doing that, the child's hips and leg will be flexed. And for the Kering sign, is also the child is lying in supine position. So this is when the thigh is flexed at the hip and knee at 90 degrees angle. The subsequent extension in the knee is going to be painful. The child will show like a sign of pain in his face. So that's lead to a resistance. Okay, next. So for the bacterial meningitis, it is a serious infection in children with a 5 to 10 mortality, and over 10% of the survivors are left with a long-term neurological impairment. It's characterized as a continuous fever. So the pathophysiology of it is the baby will get or the child get the bacterial infection. And there's going to be a bacteremia. The bacteria is entered to the blood vessels, crossing the blood-brain barrier and causing infection, releasing of inflammatory mediators and activate the leukocyte, and also will do the endothelial damage, resulting in cerebral edema, rise in intracranial pressure, and decreased cerebral blood flow. That will lead in abnormality in the blood vessels. The vasculopathy will lead to a cerebral cortical infarction and vibrate deposit block in the resorption of the cerebrospinal fluid by arachnoid villi. And this is all will lead to accumulation of the cerebrospinal fluid that occurs within the brain and causes increased pressure inside the skull, which is as defined as hydrocephalus. Next. So now we have how to diagnose the meningitis. So here in the small table we have the organism that might cause bacterial meningitis according to the age. So we have from neonatal to the 3 months. It could luckily to be get a group B Streptococcus, E. coli, and Listeria monocytogenes. The Listeria monocytogenes is appear in the food-borne, dairy product, processed meat, uncooked vegetable, and affected the immunocompromised patient. And from 1 month to 6 years, likely to have a Neisseria meningitis, a Streptococcus pneumoniae, Haemophilus influenzae. In more than 6 years, the patient could have the Neisseria meningitis, and Streptococcus pneumoniae. What is known about the Neisseria meningitis is infect the children and the young adults, and it's the only organism that causes meningitis epidemic. The evidence is suggests that the Streptococcus pneumoniae occasionally infect the children and increase in incidence with the age. So here are some investigations that you can do to diagnose the baby patient with meningitis. You can do the whole blood count, blood glucose, C-reactive protein, but the most important thing that I would like to highlight is the lumbar puncture test for the cerebrospinal fluid. So you can look at this table. There are several conditions with the bacterial meningitis. Let's take the first one, the acute bacterial meningitis. The leukocyte here is the unit that they use here is the cubic millimeter of the cell. The normal range is 5,000 to 10,000 cubic milliliter. So here is state that it's range from 100 to more than 50,000 cubic milliliter. The protein is going to be usually from 1 to 5, which is high. The normal range is from 0.5 to 1. The glucose is going to be low, is less than 0.5 to 1.5. The comment is the gram stain may be positive. For the partial treated bacterial meningitis, the leukocyte is going to be less than the acute one. It's from 1 to 10,000 cubic milliliter. Is usually high in the polymorphic nuclear cells, but it may have a lymphocyte. The protein is going to be high, is more than 1. Glucose is going to be low. The comment is the cerebrospinal fluid might be sterile in pneumococcal and meningococcal meningitis. So this is the most important two things in this table. The next slide. Okay, for the meningitis management, I would like you to pay attention to the algorithm first. So what you will start with is to see and inspect the child or the patient that he has fever and symptoms and signs of the bacterial meningitis. You will perform a lumbar puncture test and check if the patient is contraindicated or not. If the patient is contraindicated, you will refer to the box with the red bar. The contraindication is the patient is hemodynamically unstable, which is the perfusion is failed. The Glasgow coma is scale is equal or less than 8. The abnormal doll's eyes, reflex or unequal pupils, and there is an abnormal posturing, and look or check for any recent seizure. And in very rare cases, there is presence of popliteal edema. Okay, for the if there is no contraindication, you will perform the lumbar puncture test. You will do the blood and urine and culture and sensitivity. You will perform also the urine streptococcal pneumonia antigen and start antibiotic with dexamethasone. If the cerebrospinal fluid is abnormal, you will continue with the antibiotic. If there is an improvement, you will refer to the label to the table in the left side. So they divided based on the age group from the less than the 1 month to 3 months. They have the same antibiotic, which will start with the C-penicillin with the cefotaxime, but the duration of the therapy is going to be different. And for the child for the baby is more than 3 months, we'll give the C-penicillin. But here you can choose if you want to to use the cefotaxime or ceftriaxone. Also, the duration of the therapy is going to be different. So you can refer to this table later. So if the antibiotic shows no improvement, for example, the baby is still have a fever for more than 3 days and have a neurological defect, so consider the ultrasound and CT brain and repeat the lumbar puncture if no evidence of the rise intracranial pressure. And then change the antibiotic if there is no response, so it consider it as a TB or fungi or encephalitis. If there is a response, so complete the course of antibiotic. But what if the cerebrospinal fluid was normal from the very beginning? So you need to wait for the cerebrospinal fluid culture and latex agglutination. If it's positive, you will do the whole procedure that I have mentioned before. And if it's negative, you will reevaluate and consider discontinue of antibiotic. And it's might not the child might not have the bacterial meningitis. And also, I want to like to add for the management is the follow-up. Long-term follow-up is important. You cannot if the development of the child at home or in school, and also note the head circumference because of the hydrocephalus, and also assess for the vision, hearing, and speech. Okay, next slide.
Okay. Stop there a second. Second.
Okay.
Before we move on. I think it is important that all children whom you suspect meningitis needs lumbar puncture. Okay. Provided there's no contraindication, like you mentioned, isn't it? Those are the contraindication for lumbar puncture. Please do not do it when it's seizure or hemodynamically unstable or whatever lah, okay? Whatever is there. So something to do with increased ICP, please do not do it, or else you're gonna kill the child. So if the child is okay and stable hemodynamically, then you should. So the purpose of doing lumbar puncture is to identify the organisms. For example, like on the left hand side, there you say group strep. Who gets group strep? Anybody who gets group strep? Kaplan? Group strep, who gets it?
Post-pregnant woman.
Okay. So let's see 1 month. So 1 month is GBS. So GBS is all women lah. So you need to ask what question you need to ask when you ask for, when you suspect a child less 1 month old who has meningitis, features of meningitis. So history, what history should you be asking? Anis? Anis? Where are you? Nobody. Okay. Huh?
History, with meningitis, is it?
Sorry, I couldn't hear.
Is it history of the child who suspected meningitis?
Yeah, one is meningitis. What are the risks? If you think of GBS, what are the things that you need to ask in terms of questioning to pinpoint the risk of GBS? Amelia?
Yes, doctor. Is it whether the mother have the rectal vagina group B streptococcus?
Okay. Anything else? Vagina swab with GBS. Anything else?
Whether there is a premature rupture of the membrane.
Okay. Anything else?
Is it the laboring is like prolonged, or the mother have fever before that?
Thank you very much. You're good. Okay. So Amelia, you're very good. So asking the risk related to GBS, such as prolonged rupture of membrane, premature prolonged rupture of membrane, what you call maternal parexia. That's correct lah, isn't it? Maternal history of a high vaginal swab with group B strep or group B strep in the urine or low vaginal swab, whatever lah. Or chorioamnionitis, history of chorioamnionitis. Then you are likely to find the cause of it. If it's E. coli, Sabrina, who gets it? E. coli? Sabrina, are you around?
Yes, yes, Doctor.
E. coli. Who's at risk of E. coli?
Immunocompromised.
Immunocompromised, anything can go with any organism. E. coli? History of what? If there is any?
Is it meconium?
No.
Aspiration?
E. coli can be related to either metabolic problem, for example, like galactosemia, or baby who has history of infection lah, isn't it? E. coli lah. So which is urinary tract infection lah. Haemophilus influenza, who gets it? Unvaccinated lah. More unvaccinated, because nowadays we see all children are vaccinated, so we don't tend to see Haemophilus influenza nowadays. So those who are unvaccinated, so that's why unvaccinated Haemophilus influenza can also develop epiglottitis, isn't it? Because they're not vaccinated. So similarly to Haemophilus influenza B, if they're not vaccinated, then they can get infection of the what you call meningitis as well. So I think that's number 2. Number 3, over there, you know, on your right side there was a mention, Arwah, can you why are we giving DEXA?
It's stated here, it reduces the risk of long-term complications such as stiffness.
Yeah, okay. So it will reduce. So, but then like it's only for specific organisms, not all. Okay. So if it's E. coli meningitis, you can't give DEXA because E. coli meningitis is a gram-negative organism. Gram-negative organism is devastating. It can kill you. So like group B strep those are gram-positive. Gram-positive is not. I mean, they can kill as well, but it's not that devastating. But then like which one? Usually Haemophilus, you know, Haemophilus strep. I think you can also give dexamethasone. But the rest of them like E. coli, you don't need to do it, or even EBS. Anything else? Why is it important? I mean, like the other thing which is important, Neisseria meningitidis. Why is it important to identify Neisseria meningitidis?
Antibiotic treatment.
Yes, I know. Yep, antibiotic treatment, correct. But the other thing is, you don't know where Neisseria likes to stay. Where does it stay? Commensally. Maybe some of you have Neisseria. In your nasopharynx, okay? So Neisseria can live on your nasopharynx without doing anything. But once you reach the barrier, you know, when you have injury or whatever to your nasopharynx, so the barrier is breached, so the organism can enter the brain and causing meningitis. So how do you eradicate Neisseria? Akmal? Akmal, are you here?
Yes, doctor.
So how do you eradicate Neisseria? If there is, because I mean, like the most important thing is you do LP. You want to know the organisms. If you know the organisms, you can determine, Okay. If it's E. coli, where does it come from? If it's Neisseria, yeah, it might be in the nasopharynx area. So what do you do for contact? Anybody? Miss Shalini? Anybody? Miss Shalini? Where are you?
Yes, doctor.
So what do you reckon?
We can give antibiotics.
Yes. What antibiotics?
Rifampin.
Rifampicin. Okay, one of the things, I mean, like, that's why it is important to do LP, because you want to establish what organism it is. Once you know the organism, then you can treat those who are close contact, who might also get Neisseria as well. You know, so that in order to eradicate it, you use rifampicin for 2 to 3 days. I think 3 days, if I'm not mistaken. 3 days to eradicate rifampicin in the nasopharynx area. So that's about the gist of this. The other thing that you mentioned about subdural empyema, brain abscess, if it's inadequately treated, all these organisms is inadequate. So you manage by 7 days. I mean, if the organism is not eradicated, therefore it can develop into empyema or abscess, and which might come again. So that when you are getting all this infection, then you need to extend the antibiotic therapy maybe to up to 6 weeks to cover this. So you want to ideally you don't want to get the patient to 6 weeks antibiotics, staying on the ward for IV antibiotics. You want to eradicate as quick as you can. Maybe around 14 days will be sufficient. Ceftriaxone cannot be used for children or babies under less than 3 months. So that's why you use cefotaxime. Okay, I think I'm talking too much. Okay, next.
Okay, then we have the viral meningitis. It's account for 2/3 of central nervous system infection. It's much less severe than the bacterial meningitis. The viral meningitis is last in severe cases is about 7 to 10 days, with the symptoms receding gradually. In most cases that present clinically with meningitis are self-limiting and carry a good prognosis. While the bacterial meningitis is cured by the antibiotics, so we need to assess the management as soon as possible. So the pathogen that, the type of virus that might cause the viral meningitis is the enterovirus, Epstein-Barr virus, adenovirus, mumps, and West Nile virus. The diagnosis is by doing or performing the culture of or PCR of cerebrospinal fluid, stool or urine culture, the nasopharyngeal aspirate or throat swab cultures, serology. Next slide. The second point is would like to talk about is the dengue. Dengue is an infection is caused by the dengue virus that is belong to the family Bulbiviridae. Is characterized by saddle back fever alternating febrile and afebrile of 2 to 3 days each. There are 4 serotypes: dengue virus 1, 2, 3, and 4. It's transmitted to humans through the bites of infected Aedes mosquitoes. It is primarily transmitted by female Aedes aegypti, a tropical and subtropical species. So you will see in Malaysia, but in my country, it's going to be very interesting if you have a patient with a dengue fever because it's very rare. So the human is the main host of the virus. So the incubation period is range from 3 to 14 days. So after that, after 4 to 10 days of the incubation period, the illness begins immediately. Next slide. So the epidemiology of the dengue is during the period of 2000 to 2019, the annual number and the incidence rate of the dengue cases in Malaysia varied substantially. From the lowest value of more than 7,000 cases in year 2000, reaching a peak of more than 120,000 cases in 2015. And after the peak, there was a downward trend in the 2016 and 2018, 2017, with a yearly reduction to 3.9% of the cases respectively. However, in 2019, there was an increase of 61.4% of dengue cases. So we can conclude that the dengue virus is affect all age groups worldwide. Thus, the children are also not spread from dengue infection, and their management proves to be challenging. Next slide. So the latest classification of the dengue is by the WHO in 2012. They classify as dengue with the present and absent of warning sign and severe dengue. The first classification is dengue without or in absence of warning signs is called probable dengue. The patient will characterize with fever and any two of the following: the nausea, vomiting, rash, aches and pain, positive tourniquet test, leukopenia. The laboratory confirmed dengue. Make sure if there is a presence of plasma leakage or not. So the next is the warning sign. The clinical manifestation is there is an intense abdominal pain or tenderness. There is a persistent vomiting and clinical fluid accumulation, mucosal bleed, lethargy, restlessness, and liver enlargement more than 2 centimeters. So in the laboratory investigation, the AST and ALT is going to be elevated. There is going to be an increase in hematocrit with concurrent rapid decrease in the platelet count. The second classification is the severe dengue, which has three main criteria. The first one is severe plasma leakage is leading to shock and fluid accumulation. The second criteria is severe bleeding. The third one is a severe organ involvement, such as the liver is going to be elevated in transaminases, as I mentioned. The AST and ALT is going to be more than 1,000. For the central nervous system, there is going to be an impaired consciousness and seizure. For the heart and other organ involvement, there's going to be an abnormality in it, but not in all cases. So next slide, please. This one that I have just explained. So next. So this is the phases of the dengue in relation of the clinical manifestation. So first phase is going to be a febrile phase. It is an early phase of disease, and it is difficult to differentiate the dengue with other childhood illnesses. Therefore, they perform the tourniquet test with the full blood count. So in this phase, it usually lasts from 2 to 7 days. The common feature is going to be high-grade fever, facial flushing, skin erythema, generalized body ache, myalgia, arthralgia, retroorbital pain, photophobia, and rubiliform exantha, which is a rash, which is characterized as a pale pink or less widespread. Tiny flat macules separated by the area of the healthy skin. And also the patient will have headache and present with anorexia, nausea, and vomiting. The second phase is the critical phase. Usually begins after the third day or third day of illness, but it can be late as day 8 of illness. So they typically occur around the time of differences. The temperature will drop to the temperature is going to drop and remain below 38 degrees Celsius. there is going to be a plasma leakage and the first manifestation of shock. The last and third phase, is the recovery phase. Most cases of severe dengue will enter to the convalescent phase from 24 to 48 hours after the onset of the plasma leakage, and there's going to be a gradual absorption of the extravascular compartment in the next 48 to 72 hours. The important sign to be considered is the body is finally getting improved, and the hematocrit might be increased due to the dilutional effect, and there is going to be a new onset of respiratory distress due to the fluid overload. Okay, next slide. So this is a chart that is illustrates the phases of dengue in relation of the symptoms and laboratory changes. So you can see that each phases that has its own symptoms, like febrile, it starts with dehydration and febrile seizure. The critical phases will start with shock and bleeding, and recovery will have the reabsorption of the fluid, fluid overload, and pulmonary edema. And you can see the laboratory investigations such as the hematocrit and platelets and the IgM and IgG. Okay, next. You can refer to it later. Next is how to diagnose the dengue. So first of all is to do the clinical laboratory test. You will perform the result is going to be for the white blood cell and platelets and hematocrit there's going to be a decrease in it, and there is the albumin is also going to be declined. It's called the hypoalbuminemia because the albumin and other smaller plasma protein is leaks from the blood vessels. The AST and ALT is going to be elevated. You will also may perform the chest X-ray because the dengue fever is complicated by the lung infection, and also there is a dengue specific test which is done before day 5. You can perform antigen detection and PCR and viral isolation, and after day 5 you can do the ELISA and ICT to check for the immunoglobulin levels. Okay, next slide. The last slide for me is the management. So the important thing is the timing of the intervention, that is start of the front line of the healthcare and personnel, whether they are in A&E or OPD or even in the health clinics. And also you need to do early recognition of disease, and careful monitoring of IV fluid is important right from the beginning. Try to replace the lost plasma and prevent the fluid overload. And also the first thing you need to do is establish if the patient have the dengue or not, and then determine the phase of illnesses that I have mentioned before, the febrile and critical and recovery phases. And then recognize if there is a presence or absence of warning sign and severe dengue. So here in early phase of the disease, it is difficult to differentiate dengue with other childhood illnesses. So yeah, I mentioned this before. The last point is the temporal relationship of the fever cessation. When you try to drop the temperature, it is important in dengue. There is manifested severity like the plasma leakage or shock, and when the temperature is seen to have a decline. Okay, that's it all from me. Do you have any question?
Yeah, I think we'll go ahead. Okay, this is the last part, isn't it?
Yes.
Okay, right.
Okay, so next is regarding febrile neutropenia.
So febrile neutropenia is a common complication in children that receive chemotherapy for cancer. But of course, it also can be due to other reasons other than chemotherapy, for example, medications and also certain disease. So febrile neutropenia is characterized by fever equal or more than 38.3 degrees Celsius, and the neutrophil count is less than 500 cells per millimeter cubic. So how febrile neutropenia can happen? So from what I tell you just now, it is a common complications of the chemotherapy. So when the patients receive chemotherapy, chemotherapy will target the rapidly dividing cells, which is such as myoblasts, which is we know myoblast is a precursor of neutrophil. So when the myoblast is attacked, then the patient will develop neutropenia. So when patient develop neutropenia, there will be high risk of developing life-threatening infection. So the sources of the infection can be transmitted from other infected persons or can be from the organisms that resides in the mouth, gut, skin, and also from the lungs. So for the common pathogen that cause febrile neutropenia in children, it can be bacteria, fungi, or virus. And for the gram-positive bacteria, the etiological agents can be like Staphylococcus, Streptococcus, and others. For gram-negative bacteria, can be E. coli, Klebsiella, Pseudomonas aeruginosa, and others. For the fungi, Candida species, Aspergillus, Cryptococcus neoformans, and for the virus, such as herpes simplex virus, varicella zoster, and so on. Okay, so regarding the investigations, so first and foremost, history taking and examinations is very important in order to identify the possible sources of the infection. So for the history taking, the questions that can be asked like do the patients receive chemotherapy before, or maybe any use of medications. And for the sources of infections, further questions that can be asked is either patients have any urinary symptoms, shortness of breath, or any catheter placed recently, and any changes of the skin. So this can give a clue to identify the sources of the infection. And then after that, it will proceed by the investigations, which is full blood count to identify the level of the neutrophil, then C-reactive protein, and then chest X-ray if indicated, and bacterial and fungal cultures. So for the cultures, the sample can be taken from the blood, urine, stool, or wound. And during that time, if the patients present with the central venous line, so we need to take culture from that too, because as I said before, line can be one of the sources of the infection. And because the line usually infected by gram-positive bacteria, so we need to cover by anti-staphylococcus, for example, Coxsacillin. Abuse examination will be done if necessary, because some of the patients that undergo chemotherapy might receive the nephrotoxic drugs, for example, cisplatin. And then febrile neutropenia basically is a medical emergency, so we don't need to wait for the culture results in order to give treatment. So we need to treat patients empirically by broad spectrum antibiotics, for example, cephalosporin, aminoglycosides, and after the results is available, then we will change into the specific antibiotics. Then after the treatment, if the temperature settles and then the culture turns up positive, so patients need to be treated 7 to 10 days, depending on the organisms isolated. And if the culture negative, patient can be considered discharged if patient's condition is well and they remains febrile for 24 to 48 hours. But if the temperature is still persists, even after 2 to 3 days, then repeat the cultures, consider to change the antibiotics or add the systemic antifungals. If the fever still persists after that, then reassess need to be done, which is look for occult infection, repeat the chest X-ray, repeat the cultures, echo and ultrasound, add antifungals or change the antibiotics. And then if the patients presents with central venous line, then consider to remove it if suspect any resistance of catheter-related bloodstream infection. And then the last one is for the management. So as I said just before, febrile neutropenia is a medical emergency. So patients need to be treated empirically. So patients can be treated either by monotherapy or combination therapy, but monotherapy is safer because it just consists of the one drugs only, which is cephalosporin. So it can be either, for monotherapy, it can be either ceftazidime, cefepime, imipenem, or meropenem. For the combination therapy, is a combination of cephalosporin with the beta-lactam antibiotics or aminoglycosides. For example, ceftazidime combined with the amikacin, or ceftriaxone combined with the amikacin, or piperacillin combined with the amikacin. So for both therapy, if there is any suspicion of the MRSA infection, then need to add vancomycin. And then after 3 to 5 days receiving the antibacterial therapy, patient's conditions need to be reassessed, which if the patient's responding, which is the patient's condition become better, then continue the antibiotics. And then after the blood culture results is available, adjust the antibiotics. And if the fever is still persists, even after 5 to 7 days, then consider antifungal therapy.
Stop there.
Okay.
Monotherapy is, you don't use monotherapy, okay? You need to use combined therapy. Why? Because this is febrile neutropenia, and this is for cancer children who are, having neutropenia. So you do not know what's the organism. So you don't try to gamble using only monotherapy. So you need to cover a combined therapy, cover gram-positive and gram-negative. That's why the drugs, you say about beta-lactamase, etc. It's not about that. It's about covering gram-positive and gram-negative. So you're trying to combine and then try to cover as much as you can. If it's not working, then if you grow MRSA, then you've got to tailor your cover according to MRSA lah, for example, vancomycin. But if you cannot still grow any bugs, therefore the next step will be antifungal, because you're covering gram-positive, gram-negative, and then you're not growing anything. So unlikely to be gram-positive or gram-negative. So what are the organisms then? So it will be fungal lah, okay?
Okay.
Or maybe some exotic stuff like Cysticerina, like that. Okay? So maybe some other very weird organisms. Like you cannot grow any normal organisms or colonizers from the line or from the blood cultures or from any sites might trigger the febrile neutropenia. So therefore, you need to make sure that you also cover other organisms which is outside the gram-positive and gram. You can't take. You mentioned about virus. If it's virus, then depending on what type of virus you have, varicella, then you can cover with acyclovir instead of covering with antibiotics. So I think those depends on what your the underlying etiology or your workup or your suspicions. So as long as you cover gram-positive and gram-negative, if in a center where you've got resistance, then you might want to escalate to meropenem or imipenem or whatever lah. But ideally, you should try to combine between gram-positive and gram-negative. Ceftazidime and amikacin would be okay, and then if you find resistant, then you have to tailor accordingly. You're fine. Okay, it's not monotherapy. So I don't know where you took this, so it's wrong. Okay, it's not monotherapy. You should combine it. Okay, thank you.
Okay.
Doctor, I have a question.
Yeah.
Regarding meningitis management just now. For example, if the parent refused for the baby to get lumbar puncture, how are we going to start the management?
Okay, so that's ethical problems. Okay, ethical issues. Okay. Ideally, if you cannot get the lumbar puncture, if the parents are allowed to refuse because they are the sole guardian of the children. So therefore, whatever decision they make, as long as there's no harm occurred to the child, that should be okay. If they refuse to take antibiotics, then that's harm that will be, that can occur to the child, and therefore you ought to use whatever power, means, child act to protect the child from being harmed, because this is something reversible, not like something irreversible. So that's number one. Number two, I mean, like if they still refuse after giving the information and have false ideation on the on the intervention, like for example, like Kelantan here, a lot of parents refuse to get the number budget. It's all bogged down to your communication, because I mean, like I often, being a bit paternalistic, I don't want to be defensive. Can I do this? Can I do? Yeah, come on. Yes, you can. I mean, you're doing it, for the sake of wanting to determine. It's not like you want to harm the child. You want to determine the organism itself. So therefore, I usually, say I want to do rather than can I do it. You know what I mean? So it's all about you trying to portray the perception or confidence to the parents, and then the parents, might might not want to do it because they hear some some rumors about that lumbar puncture can cause brain damage, etc. Wrong. So basically, I mean, if they don't do it, then you just cover it, with antibiotics. But provided you got to tell the parents that, because we do not know the organism, then the likelihood that the child will be, will be staying in the ward maybe for 2 to 3 weeks, according to the what you call response of that antibiotics. Because I mean, like what you don't want is that to treat the child, and then suddenly the child deteriorated because you don't give adequate antibiotics cover, because of the because of the organism. Often, a lot of antibiotics that was proposed there is the broad spectrum antibiotics, so it should be okay to cover any single bits, as long as you don't get gram-negative organism. Whatever things that you may not be sufficient. Okay? Is that answering your question, or am I just
Yes, doctor. Yes, doctor. Thank you.
Okay, I hope it's answer. Clearly, parents have the right to say no to lumbar puncture. Clearly, but I don't tend to do that. I want to know because of the consequences that I discussed earlier on about the treatment, for example, treatment of the close contact. If this is really Neisseria meningitis, if it's Neisseria, then we ought to treat the close contact, i.e. the parent, i.e. the siblings, and other close contact in the household. Okay, and the other thing as well is probably suspicious of Haemophilus or strep. Therefore, you can start on DEXA, but that can be very difficult. Sometimes it's very difficult to start because you're not. Right, next. Any other things? Okay, sorry. Dengue, I think, is comprehensive, quite comprehensive, because this is an endemic disease in Malaysia. It's it's an urban disease. It's not a rural disease like malaria. I've been here for a long period of time, but I've never seen malaria here. But when I was in the UK, I saw many malaria because they are just traveling back from Asia and coming back to the UK or the West. So you see a lot of malaria because they come back from Asian or African country, whereas you don't tend to see in Malaysia. I mean, although it is a disease where in a rural setting, but sometimes it's not really managed. Sometimes not managed here as well. So then, dengue is very important, as you said just now. It has the most important thing is about different version. I mean, like different version period, whereby you got capillary leakage. and where the most important is meticulous. Whatever we do is always meticulous, because it's the blood, the dengue is all supportive care, and if you do not careful, supportive care, if bleeds, if they are short, they're not short, you just give maintenance. They're bleeding, you give blood, whatever it is, just to support. And you need to be able to assess the patient concisely, because if you assess it, if you assess it banky, and therefore either you overestimate or underestimate, and if you give too much fluids, you are the one causing them to be having sequelae of overhydrating or underhydrating. You know what I mean? So this is vital. It's important for you guys when you become a doctor later, is to make sure that things that you do, appropriate assessment is very, very, very important. Okay. Okay. Anything else? Any other question? I think everybody is tired now, isn't it? Any other question to the speakers, or somebody asking me? Okay, Mustaqim. I've forwarded to Mustaqim about tomorrow. There will be a basic science CME, not night. Mustaqim, read it. So tomorrow there will be basic science on fecal circulation and PPHN around 8:15. Okay, Mustaqim, can you please forward to your friend? I'll forward it here. Okay.
Already, doctor. But is it on night or morning?
No. 8 in the morning. Come on, man.
Oh,
8
okay,
in the
morning.
Tomorrow.
Okay.
We're not. Whatever I forward to you, it will be all in the morning activities, department activities. You are all in pediatrics, aren't you? Kan? So everything, it will be. I think Mustaqim, can you forward it to your friend?
Already in WhatsApp.
In WhatsApp, okay. So tomorrow there'll be basic science, and therefore, please join. I will forward from time to time whatever activities that we have. But if it's inappropriate to you, for example, like research, it's not appropriate to you. You don't need to do it. But if it's basic science like this, then you should be joining us. But in pediatric department, so therefore, I expect you guys to join us. Okay. Okay, it's 4 o'clock now. I think we better stop here. Okay, is that all right? Any other last question? With regard to the topics, comprehensive topic. Okay. So then we stop here.